Okay, we're here to talk about core stabilization and joint dysfunction, SI joint dysfunction. A little bit of review. The SI joint is formed between the sacrum and the ilium bones. This joint is classified as both diarthrotic and synarthrotic. The synarthrotic joint comes from the sacral tuberosities in the iliac that are connected by ligaments, and the diarthrotic joint comes from the sacral and iliac auricular surfaces. There's not much movement in the SI joint due to all the ligamentous support, and they have both intrinsic and extrinsic ligaments. Extrinsic ligaments are sacrotuberous, sacrospinous, and iliolumbar, and the intrinsic ligaments are the short SI, the long SI, anterior SI, and posterior interosseous.
Okay, sacroiliac dysfunction, or SID, describes any pain associated with the sacroiliac joint, and this includes inflammation, strains, or sprains. Some causes of SID: you have hyper or hypomobility of the ilium, and this can be caused by systemic mobility, sedentary lifestyle, or hormonal changes. Pregnancy, relaxin is released, which causes hypermobility to allow the passage of birth. You also have leg length discrepancy and also compensation in the lower extremity. And compensations can include altered gait, injuries, returning from surgery, or even muscle imbalances. Alright, these are some of the special tests that test for any SID or sacroiliac dysfunction. So we have the March test, sideline posterior translation, SI distraction or compression, active straight leg raise, supine to sit leg length, or thigh thrust. Alright, so with the March test, what you're looking for as the patient lifts their leg past 90 degrees or flexes their hip past 90 degrees, you're looking for the ipsilateral PSIS to go down and the contralateral PSIS to rise up, and also for the sulcus to go down. Alright, for the sideline posterior translation, this picture is not correct. What we'll do is that you'll have your hand in the sulci and you'll have the patient's hip on your hip, and you'll do a posterior translation, and you're looking for any movement in that sulci. You have the SI compression, and you'll have your hands on the ASISs, and what you'll do is you'll compress them together, and this will cause the SI joint to open, which may alleviate some pain in some patients. And then you also have the SI distraction. Once again, hands are on the ASISs, and you're actually distracting those, which causes the SI joint to close, which may alleviate some pain. Alright, with the active straight leg raise, you'll have the patient lift their leg actively to see if that causes any pain, and then you'll compress those ASISs and have them actively lift their leg again to see if that alleviates any pain. Alright, with the supine to sit leg length test, you're looking for a functional leg length problem, such as an upslip or rotation of the ilium. Alright, and this is the thigh thrust. Once again, you'll have the patient lying supine, your hands are in the sulci, and you're given a to P translation to feel for any movement in the SI.
And on to the core. The core consists of muscles such as the diaphragm, the pelvic floor muscles, deep back muscles including multifidi, and abdominal muscles including transverse abdominis, rectus abdominis, and oblique abdominals, both internal and external. The transverse abdominis is a major stabilizer of the SI joint. Core stabilization has several goals. 3 of them are to gain dynamic control of the spine, to maintain neutral spine during functional activities, and to hold posture during both internal and external forces put on the body. Gluteal muscles are also another helper of core stabilization. Exercises for this are abdominal hollowing, abdominal bracing, dead bugs, bridging, planks, side bridge, and bird dog. These are all examples. Each of these can be progressed with lower extremity and upper extremity movements, adding a Bosu ball, really anything and everything. Treatment for SI joint dysfunction, it's usually treated as low back pain. Modalities that have been used to fix this consist of physical therapy, orthotics if there is a leg length discrepancy, mobilization, therapeutic joint blocks, and surgery. According to Hansen in an article that I read, stabilization exercises have been an important aspect in treating SI joint dysfunction. Strategies such as pelvic stabilization, restoration of postural and dynamic imbalance, and correction of gait abnormalities are used. And our references, and that's all we have.